We start in a half hour, no, less than half hour, 20 minutes. Greetings, everybody. Hello, Arul. Can you hear me, Arul?
Yes, yes.
Okay.
Thank you.
Where are you from, Arul?
From Chennai, India.
Chennai, India?
Yes, yes.
Oh, excellent. How are things with the corona there?
Not bad.
Okay. But some parts of the world, Mexico, Italy,
Yeah.
Brazil, those seem to be the top countries as far as commonality. Yeah, we start at in about 20 minutes.
Oh, 20 minutes. Fine. Okay.
I'll be here, okay? I'm just going to mute you, okay?
Yeah, yeah.
Hello, Noor. Can you hear me, Noor? Noor, can you hear me?
I can hear you, John.
Yeah, I'm talking to Noor she's a neurosurgery resident from Pakistan. Can you hear me, Noor?
Yes, I can hear you.
Okay, great.
I sent you the email address of Professor Tsuyoshi Izumo from Japan. He ready to join your daily neurosurgery. We contact him for more detail, please. Thank you.
Oh, great.
Professor Izumo, he know well Professor Kato.
Oh, great.
Yes,
Super.
they invited the Vietnam at least 3 times, and he already performed the surgery in my hospital last year.
Okay.
How are you, John?
Good. Took a little time off. How you been, Duong?
Pardon?
How have you been?
I'm fine, thanks. I'm at home now. I had on duty yesterday.
Oh, okay.
What about the social condition in US?
Okay. Very good.
Yeah.
Leo, can you hear me? Leo? Hi, Leo. Are you there?
Yes, Prof. Hello.
Hey, how you doing? Can I see
Yeah.
a picture there?
Yes, one moment. Yes. Yes, I'm there.
How you doing?
Hi, Prof. Yeah, hi, John. Long time
Okay,
no see.
we're connected.
Yeah, yes, we are connected now.
Okay, good. You're the moderator, correct?
Yeah, Dr. Raja?
He's the moderator?
Yes, he's the main moderator. I'm the call.
Okay, so I'm gonna stay out of it.
Yes.
I'll go 10, 9, 8, 7, 6, 5, and then he says, hi, I'm from the ACL, okay?
Okay, sure, no
Yeah,
problem.
he leads the program, and I'm
Yes.
out of it. I'm in the background.
Yeah, thank you, John.
How have you been? Are you in Japan or India?
No, I'm in Malaysia.
Oh, Malaysia, wow.
Yes, John.
Great.
Yes,
Great. That's we don't have many Malaysian neurosurgeons.
Yes, yeah, small number.
Yeah, that's great.
Hi, Dr. Lee.
Hi.
Do you recognize me?
Yes, we met in Hanoi.
Yeah,
Exactly.
that's right. Exactly.
Yes,
How are
yes.
you?
Fine. Nice meeting you here.
Yeah, me
Well, good.
too.
You guys know each other. That's great.
Yes, John.
Yeah. We met each other last year in Hanoi.
Yes, in November.
Yeah, exactly.
Everything's all set up. Gotta make sure everybody gets in. I'm sorry, Leo, I didn't show you my picture.
Yeah, yes. Yeah, John.
I'm on the beach.
Yeah, very nice background. How you do it?
I'm sure Malaysia has some great beaches.
Yes. Yeah, it looks very real. Your background.
Yeah, you can get one if you want.
Yeah.
You can on Zoom. You can get this. It comes with Zoom.
Okay. Yeah, I saw you in your room.
Yeah. Well, anybody that's listening can get a background like this.
Oh,
Uh,
okay, sure.
You just go to the video camera on your Zoom,
Okay.
open it up, and
Oh, virtual background.
it says virtual screen share, right?
Yes, yes.
Okay, click on that
Okay.
and open it up and pick an image from your computer.
Oh, okay. A green screen background. Choose green screen option.
You'll figure it out.
Yeah, yeah. Yes.
You can put Malaysia in the background.
Yeah. Okay.
There you
next
go.
time.
Okay, there you go.
Yeah. Now it's better.
Yeah. Well, anybody that's listening in the audience, you can get that virtual screen.
Yes.
You can make it professional. You can make it playful like we do, or
Yes.
whatever.
Yeah. Very nice, John.
Great platform. Once you get to know it, Leo, you'll see. Like
Yeah.
DeWong has been following us for a while.
Yes.
It really wasn't popular until Corona.
Yes.
Corona
Yeah.
made, in this country anyways, is the same in Malaysia?
Yes.
It got
yeah.
more popular during the Corona?
Yeah. Definitely more. Yeah. Even for the official one, we are using Zoom.
Oh, really? Official people? I know schools use it. A lot of
Yes.
schools use it here.
Yes. Yes. Sure. Prof.
We're gonna have a lot of people here.
Yeah.
Was this publicized with the ACLS?
Yeah. Actually, the official website is still we are revamping it. We only advertise in the Facebook, and I think Dr. Raja advertised in probably in other platform like a Twitter. Yeah, but
Okay.
not the official website. It's still not on yet the official website. Yes. Okay. See my background.
Oh, was a Corona in Malaysia. Hey, you can show your son. We can meet him. Is he there? Let's meet him.
No, they are not.
Come on, he doesn't want to meet me.
Yeah, it's quite high number. We have about 8,000 plus patient with corona.
Oh, really?
Yes, total about 8,000. Now
He's a big internet guy.
who? No.
Oh, is that your son there?
No.
Oh, okay. Okay, Noor. Can you hear me, Noor?
Hi, sir. Just
Hey, how you
hello.
doing? How you been?
Oh, I'm doing great, sir. How is doing?
Good, good.
Very nice. Very nice background.
Oh, yeah. I'm on the. You guys have to study. I can be on the beach.
Sir, what's happened to you? I've just noticed that you've got a band-aid. You've got a band-aid.
No, you can get this, Noor.
Yeah.
I don't know if you can on your laptop, on your smartphone, because you're on a smartphone, right?
Yeah. Sir, you
Yeah.
have got a band-aid on your hand. you're doing fine now?
Oh, I just had some blood drawn. That's all.
Really? Everything's okay at your end?
You know, I'm using my laptop. It doesn't have a good audio. What did you say?
Sir, everything okay at your end? I just noticed that you have got a band-aid on your hand, so I was concerned. You are doing fine now?
No, it's not. I just had to have some blood drawn.
Oh,
A
that's great.
typical test. Everything's fine. Couldn't be
Wonderful.
better. Couldn't be better. Africa's going well. DeWong says that may start some in Japan, more regular. Are you going to go to Japan, Nora? Because it seems that a lot of neurosurgeons like to go there.
Exactly, sir. I had applied for it, but in February I was supposed to go to Nagoya to attend a workshop by Professor Kato. But actually, during those days, our the borders were sealed because of the corona threat. Exactly in those days, so that's why I was not able to go. But I really want to, and actually wish to work with Madam Professor Kato at Fujita someday after this this COVID situation gets cleared. I really want to.
Oh, okay. Yeah,
Mm.
excuse me. Excuse me, Nora. I've got to let people in the room. You got to let
Yeah,
people in.
sure. See you.
Okay. Oh, a lot of people. Well, there you are, Nora. Take us on before we start. Oh, we're going to start in a few minutes.
Yes.
Leo, are you there?
Yes,
Oh,
John.
unmute. Okay.
Yes.
Okay.
Yeah.
Is the speaker here yet?
I don't think so. I'm looking at the list
Okay.
now.
Oh, we can start a few minutes late. That's all right.
Yes. Yeah. Yes, he's online already.
Is the moderator here?
Yeah. Moderator is there. Raja is there.
Can he introduce himself to me, please?
Raja, can you unmute yourself, Raja?
Hello,
Hello, how you doing?
I'm fine, John. How are you?
Okay, you're gonna run the show, okay? I'm staying out of it.
yeah.
I'm just gonna go 10, 9, 8, 7, 6.
Okay.
And then
Just
when I
wait.
stop, you go. You say hi.
Okay, just we'll check Professor Komatsu's share screen problem, because earlier we had a trial run and he could not share it. So we'll just check that and then go. Professor Komatsu, are you ready?
You wanna,
Just,
you wanna try it now?
Hear me?
Yes.
just,
Okay.
just try your share screen.
Oh.
Yeah, take your time, get set up.
Can you see my presentation?
Yeah,
Yes,
there.
excellent.
Looks great.
Okay.
Looks great.
Okay. Good.
That's good.
You might wanna make it bigger, There's an option at the bottom that makes the screen big.
Can you please make it full screen, Professor Komatsu?
No, you can make it on the
It's better
bottom of
now?
your screen. Could you explain, please?
There is a option to make this PowerPoint. Yeah,
Yeah, there you go. Perfect.
There you go. Perfect.
Perfect
Good.
now?
Yeah, that's perfect.
Okay,
So-
when we start, could you please get off the screen share? Because we want to see the introducer. Okay, yeah, that's good. Okay, you guys ready to start?
Yeah, sure we are.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hello. Good evening, friends. So these are the inaugural webinar series. I welcome you all on behalf of ACNS. We are very grateful to Professor Yoko Kato, who has formed this ACNS Education Committee under which these webinars are chartered. We hope to run this show every Saturday, 6 p.m. And in addition to the resident webinars, we have also arranged for monthly webinars from the masters in the field of neurosurgery. So I'm very pleased to invite Professor Fuminari Komatsu, who is a very leading endoscopic neurosurgeon, is renowned worldwide and is an expert in this field. We are very fortunate to have you, sir. I hereby formally invite you to begin your webinar. Please, sir.
Thank you. Thank you, Dr. Raja. Can you see my presentation now?
Yeah, we can see that. We can see that.
Okay, okay. So, I'm Dr. Komatsu from Japan, but I usually work in India, Kolkata, India, right now. But because of the unfortunate recent coronavirus situation, I temporarily stay in Japan right now. So I will share this time from Japan today. So today's my topic is endoscopic anatomy and application in various brain regions. So we will cover the two topics today. The first one is endoscopic anatomy, but this is not difficult. Just I like to show that endoscopic view is different from microscopic view. So the endoscopic view is panoramic and it has the ability to look around the corners. Please find how the structure you are familiar with are displayed and endoscopy. And second one is the latest endoscopic surgery. Thanks to the recent anatomical research and development of the technology, the purely endoscopic surgery is available for many pathologies. So please find what we can do and what we can manage by fully endoscopic surgery at present. As long as I know, the endoscopic techniques are classified into 4 categories. First one is endoscopic ventricular surgery. This surgery uses the ventricular scopes and the ETV, biopsy, septostomy, and cyst penetration can be done in the ventricle. The second thing is the endoscopic endonasal surgery. This surgery utilizes the nasal cavity and paracellular region, including the pituitary tumor and the anterior midline skull base region, can be managed by this surgery. And next one is the endoscopic cylinder surgery. The cylinder is used as a retractor in this surgery. The size of the cylinder is usually the 10 millimeter in diameter, and the endoscope can reach and manage the deep-seated interaction region or ventricular region and the guidance of the navigation. And finally, the endoscopic keyhole surgery. This surgery used the anatomical space like intradural space and extradural space. By this operation, extra axial region and the superficial interaxial region are managed. By using any of the 4 endoscopic techniques. I like to talk everything about but we don't have enough time, and also I have the strong interest in the endoscopic keyhole surgery. So today I only focus on the endoscopic keyhole surgery. This is the comparison between the microscopic and the endoscopic surgery. The endoscopic surgery need a smaller skin incision and smaller craniotomy. The endoscope directly visualize the endoscopic keyhole surgery is usually performed by manual techniques, so the endoscope must be fixed on something. I prefer to use a pneumatic endoscope holder. Pneumatic endoscope holder allowed to move and fix the endoscope so easily. This is the 4K endoscopic system. It displayed the detailed neurovascular structures. So this is essential for my operation. A specialized instrument, the scissors, forceps are also used. Stream type bipolars are also used. Angled bipolars are mandatory. And this is the clinical setting in my institute. The endoscopic holder, 4K endoscopic system, navigation system are used. This slide shows the representative of the endoscopic keyhole approaches. Representative approach is the endoscopic supra-old approach, the anterior skull base, endoscopic subtemporal approach to the middle base, endoscopic retrosigmoid to the posterior skull, and also endoscopic infratentorial supracerebral approach and the hospital transtentorial approach are available for the pineal region. Also, we have investigated the anatomy of the endoscope keyhole approaches, not only in terms of the intradural space, but also of the extradural space, such as the extradural supraorbital, extradural subtemporal, and lateral approaches. So let's see the anatomy and the surgical cases. First, supraorbital approach. This is the caliber dissection of the endoscopic supraorbital approach. We can see the carotid artery and optic nerve, and just behind the carotid artery, we can see the basilar artery, SCA and PCA. Also, the pituitary gland and stalk are visible. This is third nerve, optic triangle, tentorium, and the perforated from the pecom are clearly visible. This is the contralateral side. Also, again, the pituitary gland is visible. This is the carotid artery and some perforators. Now let's see the clinical cases. The first case is the olfactory groove meningioma. This case had the strong edema on the right side frontal wall, so the approach was down from the left side supraorbital keyhole.
テレビに出したら3階行ってもいいですね。3階行ってもいいです。
This is the video
いいよ、赤いやつだから。
tumor. The tumor was debarked
声入ってる。
and separated from the normal brain. This is the anterior focus, and this is the left side, the olfactory groove. The olfactory nerve was identified and separated from the tumor. Separation was, and also this is the contralateral side of the optic nerve and contralateral side of the brain. So this is the end of the surgery. So this is postoperative MRI showed the complete removal of the tumor with minimally invasiveness. Next is the endoscopic. So the endoscope was inserted into the extradural space of the anterior skull base. We will see the capillary section first. This is the span ridge, and endoscope go medially. We can see the anterior coronal process and the optic nerve. The sphenoid ridge was drilled off, exposing the anterior aspect of the temporal dura. Orbital roof was also removed. The anterior coronal process is identified posterior to the periorbital. And the anterior coronodectomy was performed under continuous irrigation. So this is the different feature from the microscope. Under the continuous irrigation, the bone dust was washed out, and the anterior coronal process was drilled. It became the pegacine, and then it was easily removed. And this is the drainage triangle, carotid-oculomotor membrane, carotid artery in the cavernous sinus, and proximal distal dural ring, and then endoscope proceed to the lateral space of the cavernous sinus. We can see the carotid artery and from a lateral. This is the sixth nerve and that artery of the inferior cavernous sinus. Now the posterior wall of the cavernous sinus is shown. The superior petrous sinus is displayed first, and then we can see the six nerves penetrating the Dole's canal. And then the endoscope directed to the lateral wall of the cavernous sinus. Lateral wall of the cavernous sinus was divided into two layers, inner and outer layers. And then this is the Parkinson triangle. You can see the carotid artery again from here. And this is the anteromedial triangle. This is the end of the dissection. We can see the cranial nerves related to the cavernous sinus. So let's see our clinical cases. So first case is the cavernous angioma in the right temporal tip. For this case, endoscopic extradural supraorbital approach was performed. Let's see the video. We can see the sphenoid ridge again, and it was drilled off, and the anterior aspect of the temporal dura was exposed, and the dura was sharply incised, and exposing the temporal tip. A small corneal collicotomy was made, and endoscope clearly display the tumor. The border between the tumor and the normal brain was clearly visualized and allowed to remove the tumor. The total removal was achieved, and dura was closed, and this is the end of the surgery. Post-operatively, the tumor was removed with minimally invasiveness. Now, next is the endoscopic extradural subtemporal approach. The subtemporal keyhole was made just above the zygomatic root. This is the capital dissection. Middle meningeal artery was already sectioned. We can see the DSPL. And this is the lateral wall of the cavernous sinus, trigeminal nerve. The bone around the V3 was drilled off, and showing the infratemporal fossa. The muscles in the infratemporal fossa was also removed, exposing the maxillary artery and the pterygopalatine fossa. Furthermore, the sphenoid sinus was opened from here, and the median nerve is visible from this view. And this is the lateral wall of the Eustachians tube. And the endoscope back to the anterior petrosal bone, so-called calcium triangle. So anterior petrosectomy was performed under endoscopy. And we can see there are triangle and the acoustic facial nerve. And then the endoscope advanced to the anterior to the pons, and this is the basilar artery, and also SCA and the solid nerve are visible. This is the surgical case of the extradural subtemporal. The case is the trigeminal seronoma. Tumor is located in the cavernous sinus, but partially extended into the posterior fossa. For this case, the endoscopic extradural subtemporal approach was done. The middle meningeal artery was incised, and GSPM was identified, and the ganglion ganglion was exposed. And small incision was made on the ganglion ganglion, exposing the tumor. Tumor was very soft and suckable, but for the removing the tumor extending the posterior fossa, the anterior petrosectomy was additionally performed. We identified the petrosal carotid artery here. And then comfortably, the tumor extending the posterior fossa was removed from this corridor. And this is the end of the surgery. Posterior operative MRI showed the tumor was removed into a capsular manner. Then we go to the endoscopic retrosigmoid approach. First, cadaver dissection is shown. The keyhole was made at the transverse sigmoid junction, and then the endoscope proceed the space between the tentorium and the cerebellum. We can see the trigeminal nerve, petrosal vein, and the SCA. Also, the third and fourth nerve are visible behind them. 30-degree endoscope allowed to see the course of the trigeminal nerve more clearly. And this is the petrosal surface of the cerebellum, and we can also see the trigeminal nerve and the sixth nerve, basilar artery from this view. And the 30-degree endoscope allowed to see the inside of the neck cave. And this is the cranial clinical case, trigeminal neuralgia on the left side. The MRI showed the two offending arteries from the SCA. This is the video.
Hopefully this will clear up, hopefully. Just keep your fingers crossed. Whoop. I'm sorry, folks. He fell off. Apparently, it's an issue of bandwidth. Just be patient. He'll be back, I'm sure.
Yeah, I think so. Some internet glitches are expected.
Yeah, it's a bandwidth. He's coming back.
He's coming back.
He's coming back. Hopefully it works well. Just hang on.
Yeah, there it goes. Professor Komatsu, can you hear us?
Yes. Continue.
Please continue, Professor.
Oh, boy.
He is not unmute his mic. Professor Komatsu, please unmute your mic. Professor
Oh,
Komatsu.
sorry, thank you now. And
There you
hello,
go.
can you hear me?
Yeah, we
Okay.
can hear you.
Yes,
Thank
yes,
you.
we can hear you now.
And, the offending artery was transpositioned by using the Teflon sling. And the safety decompression and no injury of the offending artery and perforator was confirmed. And then this Teflon sling was fixed on. So this is the end of the surgery. The trigeminal nerve was completely decompressed with safety. So next case is the secondary trigeminal neuralgia due to the vestibular schwannoma. The patient preserved patient had the left mild hearing impairment. So, and this is the tumor, and the offending artery was identified on the MRI, defined the tumor. This is the video of the surgery. We can see the tumor so beautifully. And also we can see the lower cranial nerves and the pica. And tumor was debulked using the QSOR. And then the facial nerve was identified behind the tumor. Also, the cochlear nerve was identified. It must be preserved. The internal acoustic meters was opened by using the bone QSOR. And also the tumor inside the canal was removed. So the tumor was lifted from the brainstem because the patient had trigeminal neuralgia. The trigeminal nerve was identified next. This is the trigeminal nerve. Also, the offending artery was identified just behind the trigeminal nerve. So this offending artery was completely separated from the trigeminal nerve. And one Teflon project was interpositioned. So this is the end of the surgery. For the preservation of the hearing function, I didn't remove the anymore. This is the cause of the facial nerve. Post-operatively, the tumor was removed and trigeminal neuralgia was significantly improved. So next case is the facial spasm. The offending artery or pica, the vertebral artery, was also associated. 2-centimeter keyhole was made at the transverse sigmoid junction. And the endoscope was introduced into the fossa. The arachnoid membrane was sharply incised. The panoramic view allowed to see all the cranial nerves in the posterior fossa. Then angled endoscope was used. Picar and the vertebral artery compressed the facial nerve. So these arteries are mobilized. The indentation of on the facial nerve was identified. So the procedure started from the vertebral artery. Teflon project was used for vertebral artery, and then again the Teflon string was passed under the pica root. One side of the Teflon string was fixed on the
Okay.
Professor
I'm
Komatsu
sorry.
has been interrupted again by the bandwidth problem in the internet.
I'm sorry about that.
I hope
You
he
just
does.
just gotta keep our fingers crossed.
These are the problems
He'll-
with modern day technologies.
Yeah,
Make-
he'll be back. He'll be back.
Yeah, sure, we hope so. Yeah, there is.
internet connection is unstable. Sorry for that. And again, the Teflon string was fixed on the dura. And this is the end of the surgery. So next is the endoscopic infratentorial supracerebral approach. First, I showed the cadaver dissection. The keyhole was made just below the torcular, and the endoscope was advanced the space between the tentorium and the cerebellum. The Garnick venous system was surrounded by tough arachnoid membrane, and it was sharply incised. Behind the Garnick venous system, we can see the linear run, also the posterior medial choroidal artery, and superior colliculus as well. So this is the clinical case. The right side is the ambient system epithelium. For this case, the procedural approach was performed. The patient was positioned in the park bench position, and the head was elevated 30 degrees. And then the scope was introduced into the space between the tentorium and the cerebellum. The tumor was clearly displayed through this narrow space. So tumor extended inferiorly was removed using angled endoscope, and also the curved suction. This is the lateral side. Also, the tumor was removed by using the angled endoscope and the curved suction. Also, the same, the superiorly tumor was removed. This is the medial. And small remnant piece of the tumor was also removed. And, this is the final view. This is the pulvina of the thymus. This is the lateral side, lateral view of the tumor cavity. And this is the medial view of the tumor cavity. We can see the compressed midbrain and the basal vein of Rosenthal. And this is the cabinoma. For this case, endoscopic hospital transtentorial approach was done. So we can see the focus and the tentorium, and the tentorium was incised around the straight sinus. We can see the tentorial surface of the cerebellum now, and also the venous system of the Garen, and the tectal plates are visible. So we can also see the inferior colliculus and the fourth nerve. From here, the cerebellum was retracted by suction, and the superior cerebral peduncle was exposed. The color of the superior cerebral peduncle was changed into grayish. The tumor was identified. So even under the deep-seated area, endoscope visualized the tumor clearly, and the tumor was removed piecemeal fashion. So also the tumor extending anteriorly is also removed, and the clear endoscopic view. This is the end of the surgery. The tumor is completely removed. Post-operative MRI showed the complete removal of the tumor. So our advantage of the endoscopic keyhole approaches include excellent visualization of various areas of the endocrine structure, and minimally invasive surgery can be done by this surgery. In my opinion, favorite candidate of this operation, endoscopic surgery, keyhole surgery, is the small tumor with presenting with cranial nerve symptom, pleural vascularization, and containing a soft or cystic component, and the normal intracranial pressure is preferred. And also the neurovascular compression syndrome is the strong candidate of the keyhole surgery. In conclusion, endoscopic keyhole surgery can offer an alternative to the conventional microscopic approaches. However, comprehensive knowledge of endoscopic anatomy and sufficient experience of endoscopy are needed for this technique. This is the end of my presentation. It is my pleasure if you had small interest in endoscopic surgery. Thank you for your attention.
Thank you very much, Professor. It was very well demonstrated. All the phenomenal videos were very interesting. It takes some real years of experience to do such kind of things in the brain with an endoscope. We sincerely thank you to be part of this inaugural webinars of ACNS, and hope to continue your support in future also. Currently, you have dealt with extraaxial lesions as well as a pontine cavernoma. There may be people who can interact with you and ask questions. But let me start with me. You showed a video of anterior clinoidectomy, right? Done endoscopically. Can you
Yes.
hear us?
Yes.
Yeah, you do. I hope you use navigation in all cases of endoscopes, right, Professor Komatsu?
Yeah, yes. I think the understanding hear me now. Can you hear me?
Yeah, we can hear you. Please.
Yeah, I think the understanding of the anatomical structure is mandatory, but of course, as you say, the navigation is a great assistant during the operation.
Yeah, that's very important. And what is your impression on using the CUSA while drilling the bone by endoscope? Because we have
CUSA.
seen, yeah, I saw you using the bone
Yes,
CUSA
yes.
for
Yeah,
clinoidectomy.
I prefer the bone CUSA rather than drilling. So because it's definitely safe, But the disadvantage is very slow. But the safety is more important for me. So.
Safety margin is
And
yeah.
this technique is also available for microscopic surgery. You can try this.
Yeah, but the concern of heat generation is a problem, I think. What is your experience in generation of heat while using CUSA?
I don't have any problem.
Because most articles regarding heat generation by using CUSA has come from Japan. It's from Professor Suzuki who has written it that article. And one of the articles I wrote in recent ACNS, the visual outcomes of paraclinoid aneurysms, also this part is mentioned, like people's concern about using CUSA. It's more heat generating than usual conventional drills. That is why I asked that question.
Yeah, might be. Always we have to care about it.
Right. Anybody else, please want to ask some questions?
Sir, myself, Dr. Puram, sir. Komatsu, sir, nice presentation, sir. Thanks, sir.
Nice to meet you on the website.
Dr. Neela is also here.
Yeah,
Hello, sir.
Okay.
Video start. Hello, sir. How are you?
Oh, I can see you. Oh, you are in
Wow.
the training theater.
They are live from the OR, I think. That's good. People are chipping from OR. Satish, are you there? Satish? Harshal? You guys there?
Raja, I'm here. I just sent a message on chat to you. A question to Professor Komatsu Sensei.
You can ask him directly, Satish. You are live.
Sensei, can you show me the operative setting image just to know how things are positioned in the OR?
Position? You're asking the position
with the endoscope and all the instruments.
It's difficult to explain it. Yeah, but anyway, the position is very important for me because I don't use the retractor so much. So I have to use just now, but anyway, using the gravity is very important to create the space for the surgery.
Hello, Harshal, are you there? Satish?
Yeah, hi, I'm here.
Yeah, Harshal, please want to say something?
Yeah, the lecture was a wonderful lecture. I think the beginning of the ACNS webinar series is up to a very good start with Professor Komatsu's marvelous lecture. That's all.
Yeah, Dr. Binoy, would you like to say something? Binoy, you're live.
Yeah. Professor Komatsu, it was an excellent presentation. I wanted to know whether you use the endo arm or endoscopic holder.
He showed that.
Yes, yes.
Oh,
I
okay,
presented a little
The
bit.
initial parts. Okay, okay,
Yeah, I used the pneumatic endoscope holder.
okay.
That's great. I see Christian in the panelist room. Christian Parmana from Indonesia. He was there with us with Professor Watanabe in Red Cross Hospital. Christian, are you there? Would you like to come in?
Yes, sir. Hello, nice to meet you again.
Hey, Christian, so good to see you.
Hi. Yeah. No, I don't have any question. It's the lecture is really clear and that's a very nice presentation. I have no question. Thank you.
Thank you, Christian. We are coming up live with Professor Watanabe soon, probably in the next month.
That's nice. That's nice.
Yeah, so see you around then.
Yeah.
So if there are no more questions, Liu, are you there, Liu? Professor Liu?
Yes, yeah, Raja, yeah.
Yeah,
It's a
Liu.
no question from me. Yes.
No question from you. So if that's all, we'll wind up this session. Thank you for all the participants who checked in.
I'm sorry.
Yeah, please. Who is this?
Yes, hello everyone. My name is Rasim. Can I ask one question, please?
Sure. Why not, Rasim? Go ahead, please.
First of all, thank you very much. It was really very interesting lecture. I'm studying neurosurgery residency in Russia in Kazan, and there should be international conference of ACNS, which was cancelled because of coronavirus.
Yeah, we know that.
Really hope to meet with many neurosurgeons.
Definitely.
Okay,
Please
Professor, can you tell me, please, if you use a 30-degree camera during operations? If so, how well does it work? Thank you.
Well, that work. But it's a little bit different from the 0 degree and also the different from the microscopic surgery, but it needs a running curve, but this is mandatory for the endoscopic surgery. So because the advantage of the endoscope is to see the rectal and corner. So this surgery is only performed under angled surgery and angled endoscope, like a 30-degree endoscope. So everybody have to practice how to use the 30-degree endoscope and manipulation.
Okay, I understand. And one question more. You also said that patients with small tumors are better for this surgery. Are there any exact sizes, or does it all depend on the particular case?
Yeah, this is, I think, a good question, but still I don't have any answer at present. I'm looking for such an indication and seeking the exact criteria or something.
Hello. Yeah,
I have
Dr.
one
Ali.
question, please.
Yeah,
Okay.
please do.
Yeah. That's all.
Please ask your question. Who is this?
Yes, may I have a question, please?
Yeah, please do.
Yeah. In MVD surgery, I saw that you make a small bone flap. It's difficult to remove the CSF, Professor Komatsu.
I'm sorry. Your question is about the CSF.
I saw you made a small bone flap. It's difficult for you to remove the CSF to relax the brain.
He's asking whether you find it difficult to remove the CSF from using a small bone flap, because the bone flap usually uses very small.
Yes,
you find it difficult removing the CSF from the brain through that small aperture. Is that what I hope it is the question?
I'm sorry, I don't understand the CSF.
No, for the brain retraction, you need to let out the CSF. So you use a very small bone flap. So he said, do you find it difficult?
To release the CSF during the operation?
Yeah. So that's the beginning lag.
In MVD.
Yes. Sometimes it's difficult. Opening the cistern is mandatory, and sometimes use the ventricular drainage as well as the lumbar drainage for the relaxation of the brain.
Thank you.
It's very important.
Komatsu sir, Ohio. Ohio sir. Yeah, Nila, you can ask your question, Nila, please.
I have a question.
Sorry, can I ask a question?
Yeah, please.
Hello.
Hello.
Bro.
Hello.
Yeah, please introduce.
Hello, there's a question from Dr. Mudasa from Pakistan. He's asking if he could visit the center of the presenter, if he could get a link to communicate with him.
I think you can directly visit his website, and the details of that is already posted in website, I think, isn't it, Professor Komatsu? You can write directly to him.
Okay.
So if there are no more questions, I think we can wind it up. Sincerely,
can I just ask one more question before you guys leave?
Why not? Please do. Please
Prof. Komatsu, thanks for presentation. Is Ali Alavi from Australia. Obviously, I couldn't see any slide from the setting of your scope. I just want to know, do you introduce your instrument through the endoscope working channels, or you just go next to your scope?
Not inside the channel of the endoscope. The instrument are applied parallel to the endoscope.
Sure. So technically, this is the endoscopic assisted surgery.
Assist, or I don't know how to call it, but
okay.
Yeah.
Okay. So you don't introduce any instrument through the working channels. The same way we normally use it for the intraventricular endoscopic surgery. So that's not the same thing.
Yes.
Okay. Thanks a lot. Very interesting.
Yeah, thank you. Thank you very much.
I have a question from Dr. Komatsu. My
question please.
Is,
who is this?
My question is why you selected the trans-orbital approach for olfactory groove, meaning nasal.
Hello.
Would be sacrificed the probability in the yes. This will bring high positivity in the frontal area of the patient. So why you didn't select transnasal approach for olfactory groove meningioma?
Okay. Hello, can you hear me?
Yes.
You're asking about the decision of the approach. I think he's asking about the decision of the approach.
That's
in the nasal or transcranial. And I think in that case, I think the tumor was extended more laterally to the midline. So I had the transcranial approach rather than the nasal cavity.
Yeah, I think. Who is this? Hello. Would you like to ask any questions? Hello. Whoever is it, he is not audible.
Professor Fulminari, taking this opportunity, I would like to ask a question off topic. Is there any opportunity to undergo practice in your hospital with this?
Sure. Yeah, anytime after the corona situation, you can visit our institute anytime if you want.
Is there any programs or by direct contact?
No, nothing. Yeah. Okay.
Okay, I think we'll wind it up here. Thank you, Professor Komatsu, for having chaired this, for being the speaker of this session. And we'll hope to see you next in another program, definitely. And we are sincerely thank you on behalf of ACNS to be the inaugural speaker of this webinar. Next week, Saturday, we are having Professor Jitang, a former professor at Beijing Tiantan Hospital. He'll be speaking on approach to skull-based lesions. And I hereby invite everybody to be part of the same. The timing is the same, 6 p.m. And this program will be continued for the next few months on behalf of ACNS. So once again, I thank you all. Thank you, Professor Komatsu. And I hope you'll have a great day. Thank you. Thank you very much. John,
Thank you.
it's up to you. Yeah, John.
Yeah, okay, very good. Very good. We ended the presentation. We gotta improve on the sound.
Yeah, that those are some.
Yeah, well, that's obviously something we work on. But yeah, thank you, Dr. Fuminari. Yeah, we have, when you have low bandwidth, the sound is not good. You know, we should check that.
Yeah, but we cannot do anything about it.
Yeah. It's okay. It's okay. We'll get better. We'll get better.
Definitely. Hey, John, I have mailed you the flyer of the next week. I hope you get it. I mailed it.
Yes.
Yeah, you got it.
Yeah. Great. We'll get better. Don't worry.
Yeah. So we'll end this. Thank you very much. Thank you, everyone. John, thank you very much for
Thank you,
broadcasting
guys.
live. Thank you. I hope we'll have this session on the YouTube soon. Right?
Okay, very good. So we'll see you next
Thank you for
week.
having us.
Yeah. Thank you. Thank you very much.
Bye-bye.
Bye-bye.
Sorry about that.
Bye.
Bye-bye. Bye-bye,
Bye.
everyone.